Three-definition, high-def view of the inside of the patient, and he's controlling laparoscopic instruments with his fingers and hands, just like joysticks, very fancy joysticks like Pilot. This is far more comfortable than this or this. So this is another view of what we're evolving to, robotic surgery for minimally invasive surgery. The patient is now on this side of the room with a technician, the anesthesia person, and a surgical assistant, and the surgeon is over here, sitting down, comfortably manipulating these instruments in a safe manner, as long as he's experienced and trained. Now this is one video, and I'm going to sort of fast forward to the good stuff. Now, just going to preface this video, again, there's a little bit of blood in here, but hopefully not too much. This is a patient with a small renal mass. This is a young patient, he's in his early 40s. He was found incidentally, he had some gallbladder pain, they did a CAT scan, they found a small renal mass. It's actually right here. It's very hard to see because it's so small. Someone biopsied this, and it came back papillary RCC. So, naturally he wanted this out, just like I would. But it's so small, and it's on the periphery of the kidney. There's no way we're going to take the whole kidney out, so we're going to do a partial nephrectomy. We're going to do this robotically, where we place those robotic instruments through 5 or 6 little half-inch incisions through the skin, and I control the instruments from outside the patient with a very experienced assistant or chief resident at the bedside helping me. So we're rolling. So the kidney's been mobilized. This is fat around the kidney. This is kidney tissue here, right here. Now you're going to see this yellow thing, which is an ultrasound probe, which I put right inside the patient so it tells me exactly where this tumor is. Sometimes we don't see the tumor very clearly. We have to rely on this ultrasound probe. And then I mark out where I need to go. These are clamps clamping the main renal vessels. The renal vein is up to the left, which we don't clamp. The renal artery is right here, which we've just clamped. We've shut the kidney down. It's like turning off the water main in the basement so it can do plumbing work upstairs. So now we're upstairs. Now we're cutting out this kidney tumor with these robotic instruments. And I can see, when I'm doing the surgery, I can see much better than this because it's high def and it's three-dimensional. But you can see there's very little blood loss here. We're cutting the tumor out with a very safe margin. We're taking some of this yellow stuff, which is actually normal kidney tissue, away with the tumor. And then we cauterize the base, very little bleeding here, and then we suture it and we close the gap with sutures. It's all done in a very controlled manner. And we try to do this fairly quickly though, because we've shut the kidney down and we want to get that clamp off as soon as possible so that the kidney doesn't undergo any harm. The longer we leave that clamp on, the more potential the kidney has of having some chronic damage. So we try to do all this within about 15 or 20 minutes, all this cutting out the tumor part. And again, I have a very experienced assistant helping me out, otherwise there's no way I can do this by myself. And we close this, and in the end,
For scale, how big are those instruments actually?
pardon me?
For scale on the pictures, how big are those instruments actually?
About 1 centimeter long. So now we're closing that gap. We're closing it up like a little taco, I call it. So this is a pretty standard partial nephrectomy. This can be done through either an open incision, which is traditional surgery, or laparoscopy, or another version of laparoscopy, which is this, which is called robotic surgery. They all have essentially the same outcomes in terms of cancer control. They have the exact same outcomes for cancer, and really very similar outcomes. This is what it looks like in the end. Very similar outcomes in terms of kidney function afterwards. The robotic patients tend to recover a little quicker than the open patients, as you might expect.
And do those clamps and things dissolve?
The metal clamps on the artery? No, we take them off at the end. This is us going in. After we've closed up that gap, we go in and we take them off as quick as we can to open up the kidney, let it breathe again, let it get blood, and make sure there's no extra bleeding after we take those clamps off. So this was, am I doing the time? Good? Another hour? This was our experience as of about 6 months ago. We've got pretty good experience doing this. We're up over 120 patients now. This shows the laparoscopic patients, which we did 59 of these cases laparoscopically, and at that time we did about 27 robotically. And the main point is estimated blood loss is less than 200 cc's, which is very reasonable. The warm ischemia time, which is how long those clamps are on the artery, was almost 30 minutes laparoscopically and down to about 18 minutes robotically. And the length of stay was about 2.5 days in the hospital. And the complications were very reasonable. There were 12 relatively low-grade complications in the laparoscopic group, which is a complication rate of about 21% or so, which corresponds with the literature. There were no high-grade complications. And there were 5 complications in the robotic group, again, which is about 20%. So it's not without risk. There are some patients that wind up needing blood transfusions or that get infections or bowel issues, but for the most part, we have had good luck with this approach. However, it is technically very difficult. It does require some extra training. An experienced hands, it has equivalent cancer outcomes, equivalent complications to open surgery, yet superior cosmesis and overall recovery. So that is surgery, partial nephrectomy in a nutshell. It still is the standard of care for small renal masses. So everything else I'm going to talk about are second-line treatment for small renal masses. The most common one is called percutaneous ablation. And we use either radiofrequency, which is literally cooking the tumor, cauterizing it in a very broad way, or cryoablation, which is freezing the tumor, making it into an ice ball. Whether you cook it or freeze it, the cells burst in the end, and technically the cancer goes away. Or that's the idea. However, they're both very different. So for example, when you cook an area in or around the kidney, you can potentially cook bowel or spleen or ureter or things that are in the same zip code as the kidney, and you can have some severe complications. Same thing with freezing them. So these things are not without risk. Surgery, we can see everything we're doing. In the case of robotic and laparoscopic surgery, we can see it very, very well. We can see the ureter, we can see other organs and peel them away. With these are done through CAT scan, and you can't always see clearly. You're seeing things now on a CAT scan or on an X-ray, not in real life. So you can have some severe complications with these, and particularly with radiofrequency ablation, there have been more complications than with cryoablation. Most importantly, the cancer control rate is not as good as surgery, which is why these are second line. The recurrence rate are at least 5% over 3 to 5 years, and it'll probably go up a little bit as we're able to follow these patients longer. Only small tumors are amenable to percutaneous ablation, 3 centimeters or less. Most patients who've had ablation of tumors that are more than 3 centimeters need multiple treatments, and each treatment carries with it some risk. Furthermore, we don't take the tumor out, so we're not able to analyze the pathology. We all know that's very, very important in this day and age of personalized medicine, where we're getting towards that goal of tailoring someone's treatment genetically. We'd like to have that tissue, that pathology, so we can do that. Radiofrequency ablation, the group at MGH just presented, they probably have the largest series of these patients. They're very experienced, and generally the patients do extremely well. However, there's up to a 19% complication rate, which is similar to surgical patients, but 5% of those were moderate or very severe complications, damage to other organs, damage to bowel, usually resulting in secondary major surgeries or even worse. And these complications were far more common in centrally located tumors right in the middle of the kidney, causing things like urine leaks and bleeding. So these techniques, although they're they're less invasive than surgery, it can potentially result in some very severe complications, and the patients who undergo this have to undergo some serious counseling about these risks. Cryoablation. This is a series from Cleveland Clinic. It's a little bit dated now, but it's probably the best series yet about cryoablation. It has all patients had more than 3 years of follow-up, very strict MRI protocols, and patients had biopsies after their cryoablation. Most of the tumors shrunk. 38% of them became completely undetectable, And